Hello everybody. Over the next 30 minutes we will discuss the impacts of the MRI pathway. Here are my disclosures. We should now all be aware that there are four major impacts of the MRI pathway: reduced numbers of patients undergoing biopsies and reduced diagnosis of indolent disease. And this relates to the negative predictive value of MRI. There's a greater precision of the tumor grade and volume determinations in most patients and in most centers. And for prior negative biopsy men, there is an increased detection of clinically significant cancers. So here's a study that was recently published from Canada. You can see this was a randomized study comparing systematic biopsies to MRI-directed biopsies, and you can see MRI-directed biopsies were only performed in men who had a positive MRI, that's to say a PI-RADS 3 or greater. And if you look on the right hand side there, you can see that 37% of men avoided a biopsy. On the MRI side, you can see there is about a 10% absolute reduction in the number of insignificant cancers detected, but you'll see there's only a slight increase in the detection of clinically significant disease in these biopsy naive men. And this merely confirms what we know from the Cochrane analysis, which was published now last year. And in the Cochrane analysis, again, the systematic biopsy pathway was compared to the MRI pathway, and again you can see that there is a 10% difference in the detection of clinically insignificant cancers, with fewer insignificant cancers on the MRI pathway, and about the same number of clinically significant cancers that are detected. And in this particular instance, you can see about 33% of men avoided a biopsy. So if you have a mixed outpatient population where 1 in 3 men have significant cancer, and you were to do a systematic biopsy, you'll miss 111 cancers, delaying their treatments. And remember, 20% of these will have an ISUP 3 or above, and the 700 men who don't have cancers will all need a biopsy and be exposed to the harms of biopsy to correctly diagnose that they don't have any clinically significant disease. And if you have patients undergoing the MRI pathway, remember the MRI pathway is no biopsies for negative scans and a targeted biopsy only for positive scans, you'll see you miss fewer cancers. And the ones you miss are mostly microfocal 3+4 cancers. And you'll see that only 28 men of the 700 men who don't have clinically significant disease will need a biopsy. So we can say that MRI is more likely to make a correct diagnosis using fewer biopsies in a mixed outpatient population. So question, do all men benefit from the MRI pathway? How does a positive and a negative MRI change the risk of having clinically significant cancers? Can we modify this risk further using PSA density, for example? And the fact that you've now got a roadmap, does that alter how you are going to biopsy these men? And what do you do when no cancer is found by an MRI biopsy or an MRI, but clinical suspicion remains high? So these are things that we need to still think about. So do all men benefit from the MRI pathway? Well, we now know that MRI is about 12% more likely to make a correct diagnosis than a systematic biopsy. And as we discussed previously, it's men with a prior negative biopsy who get the greatest benefit. But it's not really clear who benefits from the pathway, because very few studies have evaluated the benefits of MRI by inclusion criteria. And if you look at the EAU guidelines and the NCCN guidelines, you'll see that again they differ. So the EAU guidelines say that any person can have an MRI, whereas the NCCN guidelines continue to say that it's the prior negative biopsy men that benefit the most. And so the question we're really asking is, if you're not going to get a biopsy, then do you not get an MRI scan? And if you look at the EAU guidelines, it says that the MRI should be used when the DRE is negative and there's a slight elevation of PSA. but it doesn't mention any other groups. I don't think this question is really answered. So here's a man, for example, who has a very high PSA and is DRE positive, and you can see he's got metastatic disease, the locally advanced prostate cancer. He's got nodes in the left pelvic side wall. Does he need a dynamic contrast enhanced MRI? Probably not. Biparametric MRI will probably do. So this is a study that was recently published showing what the value of MRI might be in different types of men. So you can see that the greatest benefits, those are the blue bars, is in men with negative DREs. Less benefit for the very elevated PSA and the DRE positive patients. So let's take a case-based approach in biopsy-naive men. Let's take a man who has a PSA is less than 10 but a DRE is positive. So 58-year-old white Caucasian, slightly elevated PSA, family history, DRE positive on the right side. Should he get a systematic biopsy straight away? That would be the standard of care in some places. An MRI, that's the case in many places in Europe now. Do you need more information, or would you just discharge the patient to the GP? Well, if you look at the EAU guidelines, it doesn't say anything about men who have a positive DRE. It doesn't say you need any additional testing. So what we did was we did an MRI scan. And you can see that, in fact, the right side of the gland is completely normal. It's the left side of the gland that's abnormal. And in fact, this is a PI-RADS 2 case. So the next question we have to ask ourselves is, so does he get a biopsy? Because the risk calculator is saying there's a 13% chance of clinically significant disease, and the risk threshold is probably between 8 and 10%, at which point you would probably biopsy a normal man with an elevated PSA. Or would you say, the MRI is negative, don't biopsy, go to your urological follow-up? Do you need to know what the yields are if you did a systematic biopsy in this particular patient, given that there's no target? Or would you like to look at what the EAU guidelines are telling you about what to do with negative cases? So if you were to do a systematic biopsy in a negative case, you'll have 74 men without cancer. In other words, 3 out of 4 men would get a biopsy with its attendant side effects and not be diagnosed with a clinically significant cancer. 18 men would have indolent cancer. And so these people will be exposed to the costs and burdens of long-term active surveillance. But on the other hand, you would diagnose 8 men with clinically significant disease who would have appropriate treatment. So what this means is that 1 in every 12 to 13 biopsies in a man with a negative scan will be able to detect 1 clinically significant cancer. However, if you don't do that, then there's going to be 3 men with Gleason grade group 3 and above cancers who will be missed. And these are the ones you really want to detect straight away. So what do? Well, to minimize treatment delays missed by a negative MRI if you don't do a biopsy is to send it through an MDT, look at the risk profile, and then have a robust safety net of monitoring. So one of the ways you can look at the risk profiles is to look at the PSA density. And you can see how negative men with a very elevated PSA density of 0.2 and above have a greater than 10% chance of having clinically significant disease, and these are the men that you should really be biopsying. And in fact, that's what the EAU guidelines actually say. When an MRI is negative but clinical suspicion is low, then omit the biopsy. When an MRI is negative and the clinical suspicion is high, in other words, something like a PSA density or a family history, then undertake a systematic biopsy in somebody who has a negative MRI. And in fact, this is also what the PI-RADS committee says. The PI-RADS committee agrees and says a systematic biopsy, if the risk is high and if the risk is not high, then no immediate biopsy and a safety net of monitoring. This is a very different patient. Very similar circumstances, you can see, not an elevated PSA, but a DRE that's positive, and clearly this man has a PI-RADS 5 lesion in the left peripheral zone with extra prostatic disease. So what type of biopsy does he need? Would you do a systematic core alone, a targeted core alone, a systematic plus a targeted biopsy, or focal saturation, or do you need to look at the guidelines? Well, if you look at the EAU guidelines, it says if an MRI is positive, i.e. PI-RADS 3, 4, and 5, you need to do a combined targeted plus systematic biopsy. On the other hand, if you've already had a prior negative systematic biopsy, then you probably don't benefit, and you just need targeted biopsies alone. And this is what the EAU guidelines say. So what then is the trade-off of doing just cores anteriorly there to doing systematic plus a targeted biopsy? And what are the trade-offs here? Well, if you did targeted biopsies alone to a PI-RADS 5 lesion like this, you would detect 39 cancers. If you did a systematic biopsy as well, then this goes up by 5 cancers. So it goes up to 43 cancers. If you did a targeted biopsy alone in a positive case, you would pick up 60 indolent cancers. And if you did a targeted plus a systematic biopsy, then you would pick up another 4 indolent cancers. So the crux of the matter is that for every additional man that you pick up using a combination of a systematic and a targeted biopsy, you'll pick up 1 man with insignificant cancer. And this is the balance that you need to strike. So why is it that the targeted biopsies are missing clinically significant cancers? Well, it turns out a lot of this is due to targeting errors. You often find clinically significant cancers in sextants adjacent to the MRI target, suggesting that the targeted biopsies are missing. And we now know that if you biopsy normal appearing sextants that are away from your target, that it doesn't alter the risk stratification in the majority of cases. And we know that the more biopsies we put through a targeted lesion, the better is the yield of clinically significant disease. What we don't know is how many cores to use. It's going to be between 5 and 6 per target. And it may be that we use fewer cores for the larger lesions, but more cores for smaller lesions or multiple lesions or diffuse lesions. Or if you have a PI-RADS 3 case, or you have an anterior lesion or a very large prostate gland. So these are some of the things that we still need to work out. But the PI-RADS committee says that you should perform a systematic plus a targeted biopsy cores because it's trying to keep in step with the EAU guidelines, but it leaves the option open for you to do focal saturation biopsies. And this is what this man had. He had 5 biopsies through this lesion, and a high-risk prostate cancer was diagnosed. So we've talked about these benefits now: reduced number of patients undergoing biopsy, reduced diagnosis of indolent cancers, and this of course relates to the negative predictive value of MRI. And then we talked about the greater precision of tumor risk stratification in most patients and in most centers, and a marginal increase in the detection of clinically significant disease in biopsy naive, but quite a big improvement in prior negative biopsies. So this relates to the positive predictive value of MRI. So the question is, what is this uncertainty? What's the negative predictive value variance, and what is the positive predictive value variance? So it turns out that the negative predictive value of MRI is high, and the variability is actually quite low. And it turns out that the positive predictive value is inconstant, and its variability is also high. And I just wanted to show you that. So if you look here at 8 centers in the UK, where looking at the negative predictive value, and you can see the negative predictive value comes out at 88%. But you'll see between the centers, it's actually very, very tight. So it's a high negative value with a very low variability. That means you get consistent biopsy avoidance. On the other hand, these are 25 centers, 26 centers in the USA. and they were doing targeted biopsies alone for PI-RADS 4 and 5 lesions. And you can see that the positive predictive value is all over the place. It starts at about 25, ends up at about 75, averages off at about 48%. So you can see it's an inconstant positive predictive value, quite variable, which means that the biopsy yields are also inconsistent. So you can see how we're always trying to balance the harms from false results, false positives and false negatives, with the benefits from true results, true positives and true negatives. And we're always trying to do this, but we're being impaired by this positive predictive value that's variable, and there is also moderate inter-center variability and inter-observer variability. So how do we go about balancing the benefits and the harms of prostate biopsy? We can start off by looking at what the threshold for negative and positive cases is. We can combine MRI with PSA density. We can even think about altering the definition of what is clinically significant cancers. We can try using other alternate biopsy strategies, but all the while we need to be cognizant of both the patient and the physician's preferences and their tolerances to false results. So if you look at men, a typical man you would probably biopsy if there was 1 in 10 chance of there being a clinically significant cancer. So you're going to have patients who are biopsy averse. So these are low-risk men in the setting of, say, screening. In this case, your threshold should be higher because the prevalence is lower. And here you want to minimize overdiagnosis by minimizing false positive results, because you want to reduce overtreatments and treatment-related harms, because you know that if you treat indolent cancers, there is no long-term benefit. On the other hand, there are patients who are cancer averse. So these are patients who've had a negative biopsy before, those patients with a strong family history, those patients who have had a negative MRI but are still concerned. So for them, they are less concerned about false positives because they want to detect significant cancers that are there, because the aim here is to increase the cure rates of men with clinically important cancers. So when we talk about the benefits of a true negative is reduced biopsies and reduced overdiagnoses. The benefit of a true positive is to detect clinically significant cancer and treat it appropriately in order to cure patients. Harms are false positive, where patients undergo an unnecessary biopsy, being exposed to overdiagnosis and long-term active surveillance costs and procedures. And the other harm is a false negative, missed cancers, delays in treatment. So we want more greens, we want more reds, but we want less browns, if you like. Now when we look at the rate of positivity by the PI-RADS score, you can see that in PI-RADS 1 and 2 cases there are 6% clinically significant cancers. So these are false negative cases. In other words, the true negatives are 94%. Lots of green, a little bit of red. Okay. Now, as the PI-RADS scores go up, you can see that the rate of clinically significant cancers increase. That means that the false positives decrease as you go from left to right, from PI-RADS 3 to PI-RADS 5. So you can see the false positivity in PI-RADS 3 is almost 90%. The false positives in the PI-RADS 5 is about 30%. So you can see how we've got greens on this side, reds on this side. These are the people who are benefiting, and the browns are the other way around, and these are people who are not benefiting. Well, what stops us moving the threshold? So if we move the threshold from PI-RADS 1 to 3 and call that negative, you can see we've got more greens, and we've only got a little bit less red, and we've certainly decreased the harms, which are the brown bits. So one way of adjusting the benefits and the harms is just to move the MRI thresholds. So if you take 3 to 5, which is the conventional way of looking at it, this is really suited for secondary care, where the prevalence is higher. We know this results in a higher sensitivity, but it has a lower specificity because of all those false positives. More false positives means, as I said, more biopsies, more unproductive biopsies, and higher rates of indolent cancer detection. The real value is false negatives are fewer. You miss very few cancers, but oftentimes you will need PSA adjustments to try to make this balance a bit better. On the other hand, if you use PI-RADS 4 and 5, that may give you a better balance, usually in the setting of a lower prevalence of clinically significant disease. So, for example, in primary screening. And you can see PI-RADS 4 and 5 better correlate with the presence of clinically significant disease, grade group 2 and above, and grade group 3 and above. So it results in a better balance. And of course, for these patients, you don't need any PSA density adjustments. So let's look back and see how PSA density adjustments could be helpful for PI-RADS 3 and PI-RADS 4 cases. So you can see how in PI-RADS 1 and 2 negative cases, we said we should biopsy anybody with a PSA density greater than 0.2. But you can see in PI-RADS 3 cases, we should really be biopsying anybody with a PSA density greater than 0.1, because all of these men have a greater than 10% chance of clinically significant cancers. And of course, all men with PI-RADS 4 and 5 should get a biopsy because of the high prevalence of significant disease. If you were to just biopsy PI-RADS 3 to 5, you'll see that about 38% of men avoid a biopsy, which is roughly what we said in the previous discussion, but you would miss about 6% of cancers. Again, we've discussed this already. If we biopsied only PI-RADS 4 and 5, you'll see, of course, more patients will avoid a biopsy, from 38% to 49%. But of course, we are going to miss more clinically significant cancers. But what about if we just biopsy these patients? What would happen then? You'll see that the performance is almost identical to biopsying 3 to 5. So if you biopsy 3 to 5 alone, or only these patients here, you can see again the number of biopsies avoided is 38%. But you'll see in terms of the absolute numbers are in fact slightly different. And the number of cancers missed is also slightly different. But the advantage here is that you're biopsying men more appropriately. So these are higher risk men in PI-RADS 1 and 2 and in PI-RADS 3 cases. So these are more appropriately biopsied, although the yields may be about the same, but the men are in fact quite different. The last thing you could do is to adjust who you biopsy and how you biopsy. In the systematic pathway, everybody gets a systematic biopsy, or the MRI-Pathway, where negative cases get no biopsy, positive cases only get a MR-targeted biopsy. But what you could do in the detection-focused pathway, negative people get systematic biopsies alone, positive people get systematic plus a targeted biopsy. And this is favored by the urologist. So that's this pathway here. The MRI-focused pathway is on the right-hand side. So in the MRI-focused pathway, and this is favored by the EAU, negative cases, no biopsy. Positive cases, systematic plus targets. So you can see that there are different pathways you could employ. So the first question is, what is the added value of a targeted biopsy to a systematic biopsy? That's this over on the left-hand side. So what is the value of adding a targeted biopsy to a systematic biopsy? And it turns out it's 6%. On the flip side, what is the value of adding a systematic biopsy to a targeted biopsy? We've already talked about this. It's 4%. So here are the different pathways compared to each other. The paper is down there at the bottom for you to read, but you can see that they all give you a different balance between harms and benefits. So far we've only discussed MRI performance in a setting which is highly experimental. The real question is, how does it behave in real life? So this is a study that was recently published looking at 10 centers with more than 2,600 patients who were presenting to urological clinics with suspected prostate cancer. You can see everybody had a systematic biopsy, either a truss or a transperineal biopsy, and the prevalence of clinically significant cancers is 43%, which is a little bit higher than we were expecting. Now, if you look on the right-hand side, you can see the proportion of PI-RADS 3 cases, 24%. Now, that is higher than we would normally expect in biopsy-naive men, where we expect around about 15, 16, 17%. So that is a little bit higher, probably because we have a mixed cohort. And again, when you look at the number of cases that are missed in the 36% of men who had a negative MRI, you can see 12% of men will have clinically significant cancers. But if you biopsy these PI-RADS negative cases, you'd have to biopsy 12 to get one clinically significant cancer, and you would need to biopsy 40 to 50 for one grade group 3 or higher cancer. In other words, MRI seems to be behaving quite as we expect in the real world, very comparable to what we see in the experimental world. So here are my 5 golden rules for the use of MRI for prostate cancer diagnosis. Number 1, prostate MRI should only be used when you have a patient who is likely to benefit from the multiparametric MRI approach. You need to carefully assess the risk of significant disease using something like PSA density before and after the MRI, particularly before you offer a biopsy. And do not offer an immediate biopsy if an MRI is negative unless other risk factors are present, such as a high PSA density. You'll need to accept that not all patients with clinically significant disease will be found immediately. And so you will need to have robust safety nets both for negative cases and for positive cases after a negative biopsy. And remember that you need to use MRI methods that minimize overdiagnosis, improve risk stratification, and direct the management of your patients. Thank you very much for listening.